Great, and now we have a lightning round presentations from each of the tracks that will start after the break. So we're going to go through a quick round of the 5 tracks presenting, then we'll take a 30-minute break. You can grab lunch and then come back at 1 o'clock for the session of your choice, 1 o'clock Eastern time. So let me turn it over to the first track lead, and I'll come back before we close out this general session.
Hi, good morning. I'm Vandana Pandita. I'm the lead of Track 1, Fast Tracking Digital Data Collection and Exchange, and I'd like to invite you to join our sessions. I think you will appreciate the information that I and my other track leaders have curated for you for the next 2 days. So here are the top 10 reasons why you should join Track 1. Number 10, you are new to the Digital Quality Summit. These sessions are going to be focused on learning and understanding, and we hope that they will help you to further your participation in the digital measurement community. Number 9, you want to learn about the certification and audit process of digital measures. Number 8, you want to share your experience with others in the measurement community. Number 7, you are interested in hearing success stories from plans who reported ECDS measures for HEDIS 2020. And number 6, you are interested in hearing some of the challenges that other plans have had in reporting these ECDS measures for HEDIS 2020. Number 5, you're still trying to learn the alphabet soup of acronyms within our community: CQL, DQM, QDM, DAQF, ECQM, I can go on. Number 4, you are interested in learning about the validation process of digital data from your peers. Number 3, you want to understand how plans are acquiring or using different forms of digital data. Number 2, you want to walk away from these 2 days with a few next steps on how you can get started with digital measurement or what you can do to further your organization's engagement within the community. And number 1, you want to know the answer to why is fire so hot? So I hope to see you in one of our sessions and over the next few days. I'll hand it off to the leader of Track 2.
Thank you. So if you are really into the juicy details of digital data, Track 2 is probably for you. Even if you just want to understand a little bit more about it, we'll be reviewing an idea of computable guidelines in the 21st century. Track 2 is co-led by myself and Kristen Koska, and listed in no particular order, also features Bryn Rhodes, Brian Alper, and Matt Burton. One of the things we're going to review through our sessions is this idea of a digital and trustworthy evidence ecosystem. There are several other ways you can think about this. You saw in Chuck's presentation the idea of a clinical quality ecosystem. You might have heard this as the learning health system, et cetera, et cetera. The idea here, though, is that there is a cycle that doesn't have barriers to moving data from one part of the cycle to the other. And in this track, we'll describe how we can use FHIR in order to get closer to that ideal. You might want to think about some questions that we're going to answer during the course of our 3 sessions, like what are computable guidelines and why do we need them? What is evidence-based medicine or EBM on FHIR, and clinical practice guidelines or CPG on FHIR? How can EBM on FHIR and CPG on FHIR help drive the evidence and quality ecosystem towards a true learning health system? What are some examples of showing how EBM on FHIR and CPG on FHIR work together? And how do computable guidelines help with shareable, interoperable clinical decision support, quality measurement and reporting, case reporting for public health, registry reporting, and much more? Just as a preview of our 3 sessions, we'll give a little bit more of the context in session 1, as well as overviews of EBM on FHIR and CPG on FHIR. And on day 2, our sessions sort of split that cycle into 2, one from practice to evidence and the other from evidence to practice, using specific examples. In session 2, that example will be related to CDC's opioid prescribing guidelines, and particularly recommendation number 11 that has to do with co-prescribing benzodiazepines. And in session 3, we'll get into the severity scores for COVID-19 and the ED. And in session 3, I will mention that it doesn't follow the traditional guideline being published and then working on the digital tools. It kind of does a lot more concurrent development. And so if you're interested in seeing how that's played out, session 3 would be of interest to you. And with that, I will turn it over to the lead of track 3.
Thank you very much, Maria. Allow me to take over screen here. My apologies for premature video. Can you see my screen, track 3? Okay, so welcome to track 3. If you're a person experiencing an outcome, you may be interested in our track. Make sure I'm on the right page so I can advance the slides. So in this track, we're going to talk about patient-reported outcomes, in part because we worry about inequality, and in part because we worry that we are missing opportunities to provide the best care that we can. So we're going to talk about integrating social determinants, understanding patient experience, and understanding patient-reported outcomes through quality measurement. We welcome participants from all backgrounds and stakeholder partners. In fact, we are trying to hope that we can introduce new lenses, maybe to some of you, into how you can incorporate understanding and measuring these things and responding actionably in your own work, regardless of what the perspective you take in your own work is. We're going to look at some innovative approaches to measuring patient outcomes. And again, we're going to look broadly at patient outcomes. We're going to talk about health equity from the patient perspective. And then not to be outdone, of course, we do have to talk about the use of FHIR and standard terminologies for patient-reported outcome. But that session is also going to focus on how we implement those things in order to make them useful. On the right-hand side here, I have a slide from the NAC Human-Centered Design Framework, and we really want to make sure that we have sort of a primary patient lens as we're looking at these things. I guess not working. So for patient-centered outcomes, what are patient-reported outcomes and why are they relevant to you? Why do you care? We're going to talk a little bit about how PROs are developed and what kinds of things are measured, and then how they can be implemented. And that runs the gamut from using a piece of paper to a tablet in the office to a computer adaptive kind of model. Understanding what we mean by PROs, we're going to have 3 different groups of folks talk about how they developed and implemented PROs, and then break into smaller groups for some focused discussion. Breakout part number 2, we're going to talk about patient experience and outcomes and how those are modified by social determinants of health and health disparities. Understanding how can we adequately capture health status and relevant determinants for each of 4 different groups that we're looking at as lenses of health disparities. So we'll have a group that talks sort of generally about social determinants of health, issues that often affect people who have extreme poverty or lack of access. We're going to talk about issues around racial and ethnic health disparities, Black, Indigenous, and people of color. We're going to talk about women and family health, and then there's a group talking about LGBTQ and gender identity health issues. So if you have a specific interest in any of these, you'll be able to select that breakout room. And then, of course, we can't ignore FHIR. Of course, it's the standard du jour, correct? So when we think about patient-centered outcomes, we now have the ability to lean on an implementation guide in FHIR that talks about how to measure and implement patient-reported outcomes. We're going to consider how the patient-reported outcomes on FHIR implementation guide can support next-generation PROs, and then also talk about barriers to implementation, use, and even acceptance. The area of patient-reported outcomes is still emerging in different places, especially when it comes to patient experience and some less tangible metrics. And learning how people are successfully integrating those can help you in your scope of practice to understand how to move those forward. So the PRO on Fire IG group will talk about standards-based sort of use cases and implementation, and then we have 2 breakout rooms focused on implementation challenges, best practices, and successes using PROs. So thank you. We hope that you join us in track 3. We're trying to keep it really interactive, and we want all of you to come and to also to give your voice to the lessons learned from our group. So have a wonderful rest of the meeting, and I'll hand it back.
Hi, good morning. I'm Christine Toppy. I am the Assistant Vice President for State Affairs at NCQA and the lead for Track 4, along with several of my colleagues from states and within NCQA. This year, we build upon the public policy track from 2019 and the DQS, and will showcase states that have been implementing innovation designs, moving through the digital measurement infrastructure building journey. We have 2 states, Oregon and North Carolina, from last year, along with leadership from Colorado, Pennsylvania, and New Jersey, each featuring their experiences. In addition, we'll be focusing on what's on the horizon, including themes around data validation and integration of the social determinants of health, with speakers from NCQA, the Office of the National Coordinator, and the Gravity Project. We recommend Track 4 for state policymakers and influencers who want to learn directly from states and key stakeholders about current successes and developing work in the road to digital measures. We look forward to seeing you in Track 4. Thank you.
Good morning, everyone. Track 5, the hard acts to follow there. So after avian influenza, then Ebola, and then Zika, one of my co-workers, our co-presenters, Floyd Eisenberg, an infectious disease doc, and I have spent the last few years working the question, what can we do now to prepare for the next public health threat? To that end, we, along with colleagues from the HHS Office of the National Coordinator and the Office of the Chief Technology Officer, documented a response framework. This is new work just released in a first draft. This framework can drive the process for clinicians, healthcare informaticians, health IT vendors, and others to build the requirements needed to support a clinical response. Requirements that will serve as input to a design and build process for health IT vendors and others to implement. We call the framework Clinical Response to Emerging Threats, CRET for short. Let me break that down. A threat can be natural, think hurricanes, earthquake, wildfire, communicable disease like Zika, Ebola, coronavirus, a chronic disease, diabetes, even opioid addiction, and environmental exposure, such as a chemical spill. An emerging threat is one that may be something brand new or something that has been around for a while, but due to changes in magnitudes, the impact is now recognized as a threat to which a coordinated response is appropriate. Think the opioid epidemic or the now increasing range of some tick-borne diseases. A clinical response in that the outcome supports clinicians, whether it be implemented as decision support embedded in the EHR or simply unambiguous manual workflow. The classic case, now pick up the phone and call the public health department. On to the framework itself. It is a guide to the process of developing a clinical response, dependent on the nature of the threat. It has what we believe to be most, if not all, of the building blocks needed to build out a response. Obviously not all the detail, but everything that needs to be considered and fleshed out. Joining Floyd and I is Paula Braun, who serves as entrepreneur in residence at the U.S. Centers for Disease Control and Prevention, where she tracks evolving tech trends and helps to communicate why they matter to public health. So now the interesting part and hopefully the fun part. This is the framework. It is adaptable, it is extensible. This will not be a didactic session. We will provide an overview of the framework. Subject matter experts from other sessions will then describe 3 scenarios, viewpoints that could be applied to the framework. The first, from a healthcare consumer viewpoint, considering what might be needed for self-care and developing trust, with Laura Marshall. The second, a triage scenario from an ambulatory perspective with Floyd Eisenberg sitting in on behalf of Julia Skapik. And lastly, an inpatient triage perspective with Keith Toussaint from KMT Technologies. We, this now includes you, will then consider the measures that matter using the National Quality Forum's measurement prioritization scheme. We will do this for each scenario. These will include structural measures, process measures, outcome measures. Then we will drill down into the data requirements for each measure, considering how each will in turn inform the response to the emerging threat. To sum it up, when we are all done, we will have 1, introduced you to the framework. 2, we will have exercised the framework with some real-world scenarios. And 3, we will have extended the correct concepts to include a range of quality measures. The attendees will have concepts they can bring back to their respective organizations and in turn exercise the framework, developing clinical responses to emerging threats of any scale, both small and local or larger as needed. Finally, from a meta-quality viewpoint, I hope that this information dissemination will result in updates to the framework itself to further improve that product. No previous knowledge is required. If you have clinical experience and are interested in quality measurements, clinicians, you're welcome to join and can inform our use cases. If you're a public health professional with interest in surveillance, case investigation, population measurement, I think you will find lots of information here that you will recognize. And if you're a quality management professional with interest in data analysis and data modeling for measuring and evaluating structures, process, and outcome, you're more than welcome because you can help us extend our model with that data framework. So I hope you will consider joining us for session 5. And back to the leads.
Thank you, Dan. Wow, I thought I knew what track I was going to join, but I changed my mind 5 different times. You guys did a great job covering individual tracks, and we finishing a little early, so you now all have a break till 1:00 p.m. Eastern time, which time please come and join the working session of your choice. Those will go until 2:30 Eastern time, followed by a 45-minute break, and then we'll see you back in our afternoon general session starting at 3:15 p.m., which is a conversation with Dr. Vivian Lee and Peggy O'Kane. Thank you very much. Have a good break and enjoy the tracks. We'll see you again later this afternoon.